Hi, how are you doing, guys? It's you, Dr. Hamid, an ECVMG certified physician, and today we've got a very, very high yield revision for the whole respiratory system chapter for the USMLE Step 1 exam. So make sure to keep watching it till the end. So the stages of lung development start from the week 4 till birth till the week 36. So these are the stages of lung development. So it starts by the embryonic stage and ends by the alveolar stage. And truly, the alveolar stage extends postnatally till childhood till 8 years. So the alveolar stage starts from the week 36 till 8 years. First, the embryonic stage. So this is a period for like the anatomical parts of the lung to form. So first, of course, we will start with lung buds. So the lung bud forms the lung, like logically, and it progresses to trachea and then bronchial bud to form the bronchi. So the lung bud is like the primary origin to form the lung. Then the bronchial bud is gonna form the bronchi. So it is divided into first like main bronchus, then lower bronchus, then segmental bronchi. So all of this are anatomical data space. They want to participate at gas exchanges. So at the embryonic stage from the week 4 to 7, there will not be a gas exchange. Then the pseudoglandular stage, it means the pseudoglandular also here, no gas exchange. So this period extends a little bit longer till the week 17. So there will be formation of terminal bronchioles with like scarce capillary network. And so there will be no gas exchange structure. So errors at the embryonic stage is gonna lead to some anatomical abnormalities such as tracheoesophageal fistula. Then the third stage, which is the canalicular stage. So a very, very high yield to know that the canalicular stage is the stages where the respiration develops. So respiration is dependent on the pneumocytes. There are type 1 and type 2 pneumocytes. So type 1 pneumocytes, most common responsible for gas exchange, start developing at week 40, and the respiration is capable at week 25. So this is related to the age of viability of the fetus. For most advanced countries, it's around week 24. So this relates to the week 25 where the respiration is being capable in most cases. So it's a range about roughly week 25, and the age of development of pneumocytes is the week 20. So canalicular stage is related to respiratory bronchioles development and alveolar duct. So these are the respiratory parts of your lungs. So this is canalicular stage, then the saccular stage. So the saccular stage from the week 24 till the birth. So from its name, saccular, there will be terminal sacs. So the terminal sacs are like separated by primary septi versus the alveoli, which are like alveolar septation is like separated by secondary septi. So this is the saccular stage versus the alveolar stage. So the alveolar stage starts at the week 36 and continues till the childhood, till the child is 8 years. So the alveoli mature by secondary septation versus the primary septation that occurs in saccular stage. And the completion of the alveolarization occurs postnatally. And at birth, the air releases fluid, decreasing pulmonary vascular resistance. So the ways the baby is gonna like respirate is through aspiration of amniotic flow. So this while prenatally, so the baby is gonna respirate through aspirating amniotic fluid. So this will increase the pressure, increase the pulmonary vascular resistance. And as the child is birth, so after the mom give birth, the child is gonna like respirate air, and this is gonna decrease the pulmonary vascular resistance. So this is surfactant production and the importance. So the source of the surfactant is from type 2 pneumocytes. Very, very high yield to know that the surfactant is produced from type 2 pneumocytes. So type 1 pneumocytes is like responsible for gas exchange, and the type 2 pneumocyte acts as like a stem cell for both type 1 and the type 2 pneumocytes, and also has important role in surfactant secretion. So this occurs around week 20, starting of the development and secretion at around week 20, and the reaching like full potential and functional maturity by week 35. This is why when the baby is like born preterm, it has more probability of developing a neonatal respiratory distress syndrome due to being born before like the surfactant secretion reaching its full maturity. And the function of the surfactant is the reduction of the surface tension. So This occurs during expiration. There is a decrease in the diameter of the alveoli, and the alveoli has a tendency to collapse on themselves. So the surfactant is gonna decrease the surface tension, and it is primarily formed from a substance called dimethyl phosphatidylcholine. So this is like the substance from which surfactant is mainly formed, dimethyl phosphatidylcholine. And the clinical relevance is that whenever there is a surfactant deficiency, there is more the baby is more prone to develop something called neonatal respiratory distress syndrome, and there's a specific like ratio which is less to sphingomyelin ratio. So less to sphingomyelin ratio, whenever it is more than 2, this means like the lung is mature, and whenever it is less than 1.5, this is like more chance of the development of neonatal respiratory distress syndrome and decrease in the surfactant or the lung being non-mature. So for the surfactant deficiency or neonatal respiratory distress syndrome, to prevent this, you have to give antenatal steroids, and if the baby is born already, you may give surfactant replacement therapy for this newborn baby. We are going to talk in this slide about some common congenital pulmonary malformations. So first is a tracheoesophageal fistula. So remember from the slide of lung development, this occurs during the embryonic stage, which is the first stage of lung development. Whenever there's like defect there's like a chance of getting like a tracheoesophageal fistula, which means abnormal connection between the trachea and the esophagus. So the consequence of this, whenever like the baby is gonna like defeat, there's like aspiration. So the food is gonna go through the tracheoesophageal fistula and leading to choking and aspiration even from like his own saliva, and recurrent pneumonia, aspiration or choking. So this is the tracheoesophageal fistula. So the choanal atresia is the congenital blockage of nasal airway. So it may be unilateral or maybe bilateral, but mostly unilateral. And the condition is worse when it is bilateral, and it causes like cyanosis. The cyanosis increased with feeding. So whenever there is a feeding, there is a blockage of the mouth, accompanying the blockage already happening in the nose. So this is worsening the cyanosis and like respiratory distress, and it is diagnosed by trying to bust nasogastric tube. So there's like resistance, and we can't bust nasogastric tube. So this is like the diagnosis of choanal atresia, and the confirmation is of course with CT. So the confirmation is with CT scan, and the initial diagnosis was and like trying to bust nasogastric tube through the nose. And the condition is often part of multiple malformations. So there's a constellation of malformation happening together. So this is called charge syndrome. So the C for colboma of the eye. Colboma of the eye means missing part of the eye, mostly the iris. H, heart defect. A, atresia of the choana, or retardation of growth. And G is genitourinary defects. And E is ear defect. So again, C, colboma of the eye, heart defects, atresia of the choana, retardation of growth, and genitourinary defects and ear defect. So this is choanal atresia. Next, pulmonary hypoplasia. So pulmonary hypoplasia is also associated with some conditions. So the first sequence is called the Butter sequence. So the Butter sequence starts by bilateral renal agenesis. So there is no secretion of urine, or posterior urethral valve. So the urine is blocked. Anyways, there's a decrease of the fluid, amniotic fluid, and there's oligohydramnios. So the amniotic fluid is the ways baby of respiration. So aspiration of amniotic fluid is the baby's way of respiration while being in utero. So there is a defect here. So consequently, there is pulmonary hypoplasia. So pulmonary hypoplasia, bilateral renal agenesis, and this is also associated with diaphragmatic hernia. Next, we're gonna talk about respiratory system histology. So there are a lot of cell types and locations. So as you know, the respiratory system starts with pharynx, larynx, trachea, bronchi, bronchioles, all the way into the alveoli. So first is the trachea and the bronchi are called the anatomical dead space. Why? Because they has some role in humidification of air, clearance of air from bacteria and foreign body stores and mucus, but they don't have a role in gas exchange. So this is the trachea and the bronchi. So the main histological cell type is the pseudostratified columnar epithelium. So the pseudostratified columnar epithelium continues from the trachea to the bronchi into the terminal bronchioles, and at the terminal bronchioles there is overlap between pseudostratified ciliated columnar epithelium and simple cuboidal epithelium. So this is the area of overlap, which is the terminal bronchioles. This first. Second, you have to know that the trachea and the bronchi have cartilage. The cartilage is exclusive for the trachea and the bronchi. So the trachea and the bronchi has cartilage and also has a smooth muscle. But the smooth muscle continues all the way into the bronchioles, while the cartilage stops at the trachea and the bronchi. This is like the second important point. And there is the role again of trachea and bronchi is a mucociliary clearance and protecting the airway. It's called anatomical dead space because it does not participate in gas exchange. So next is the bronchioles. There are terminal bronchioles and respiratory bronchioles. So the ones that participate in gas exchange, of course, is the respiratory bronchioles, and there is some kind of cell is called the club cell. So the club cell is non-ciliated cell, and they have a role in the detoxification through the cytochrome B450 enzyme, and also secretes some surfactant components. So not only type 2 pneumocyte is the one responsible for surfactant component, but also club cells, which is present in the bronchioles. So this is the bronchioles. And finally, the alveoli. The alveoli contains the very high yield cell types that you have to focus on, which are type 1 pneumocytes. So the type 1 pneumocyte is like the most common cell type, which is like 90% of the surface area, and it's responsible for gas exchange. And as you see here in this picture, there's a type 1 pneumocytes. So it has some pores between them, which is called the pores of Kohn. These pores are like responsible for gonna pass gas, fluid, bacteria, and macrophages, whatever can pass between these type 1 pneumocytes. So it's most common type, 97% of surface area responsible for gas exchange. And we have some cell types which are called the type 2 pneumocytes. They are like cuboidal cells, and it has two main rules. First rule is the secretion of the surfactant. So the secretion of the surfactant also it has acted as a stem cells for both type 2 and the type 1 pneumocyte. It's gonna regenerate itself and also acts as a stem cell for type 1 pneumocytes. So this is for type 2 pneumocytes, responsible again for regeneration of both type 1 and type 2 pneumocytes and secretion of surfactant. And finally, there are macrophages, which, as you know, responsible for fighting bacteria and cytokine release. So these are the cell types that are found in the alveoli versus the bronchioles and versus the trachea and the bronchi. So this slide contains very high yield levels that you have to memorize as you may be asked about. So the diaphragm contains like some levels that's gonna be penetrated by like vessels and nerves passing from our to the lower body and vice versa. So the inferior vena cava and like the phrenic nerve or right phrenic nerve and inferior vena cava are at the level of T8, and at the level of T10 is the esophagus and the vagus. So the esophagus and the vagus are at T10. So remember, the vagus is the 10th cranial nerve, so it's gonna pass at T10, and the esophagus, of course, esophagus and vagus at T10, and at T12, the T12 is the aortic hiatus. So T12, four vessels. It's not only the aorta, it's gonna artery, vein, and the lymphatic vessels. The artery is the aorta, and the vein is the azygos vein, and the lymphatic vessel is the thoracic duct. So remember, aorta, thoracic duct, and azygos vein. This is for T12, T10, vagus, which is the 10th cranial nerve associated with the esophagus, T8, the inferior vena cava, and the right phrenic nerve. This is the structures like penetrating the diaphragm. Then the aspiration of foreign bodies at the lung. You know, like the right lung has three loops versus like the left lung has two loops because the heart occupies the left space. Anyway, the right mainstem bronchus or is in line with the trachea. So whenever you're gonna aspirate, is gonna go into your right lung. But where in the right lung? This depends on your position while aspirating. So if you aspirate while being upright, so logically it's gonna go into the lower lobe, right lower lobe. And if you're gonna aspirate while you are on your right side or lying prone, so it's gonna go into the right upper lobe. But whenever there is aspiration while lying supine, we have two possibilities, either superior segment of lower lobe or posterior segment of upper lobe. So again, to memorize that, upright position leads to aspiration in the lower lobe, while right-sided position or being prone, upper lobe. Supine position, either superior segment of the lower lobe or posterior segment of the upper lobe. And another important level, C3 and 4 and 5 keep the diaphragm alive. So C3 to 5 or the phrenic nerve supplying the diaphragm. And there are some bifurcations that happens at the level 4. So the common carotid is in your neck, so it's gonna bifurcate at C4. And the trachea is in your chest, so it's gonna bifurcate as T4. The abdominal aorta is in your abdomen, so it's gonna bifurcate at L4. So common carotid at C4 in your neck, trachea in your thorax, T4, abdominal aorta in your abdomen, so it's gonna bifurcate at L4. So again, the surfactant is a very important substance for the lungs to be more compliant and to take air. It's formed again from dipalmethyl phosphatidyl choline that is gonna decrease the alveolar surface tension. And by decreasing the surface tension, like it's gonna increase lung compliance and facilitating ventilation. And there's some type of test which is called the maturity testing, which is like by dividing the lecithin over the sphingomyelin. So lecithin over the sphingomyelin ratio, whenever it is more than 2 or equal to, this means like an indication of fetal lung maturity. And whenever it is less than 1.5, this means like it's not, probably it is not mature. And there is a risk, of course, for neonatal respiratory distress syndrome. So this is a very high yield points. You have to notice that the conducting zone starts by the nose through the terminal bronchioles. So the terminal bronchioles, um, so this is a high yield points you have to notice. First is the conducting zone of the lung versus the respiratory zone of the lung. The conducting zone of the lung starts from the nose all the way into terminal bronchioles. So the function of it again is the filtration, warming, and conduction of air. And this is called anatomical dead space because there is no gas exchange at this zone. Versus the respiratory zone, it includes the respiratory bronchioles all the way up into the alveolar sacs and alveoli. This zone is responsible for gas exchange. So this is the conducting zone versus the respiratory zone, and there's some like relations. So the right pulmonary artery lies anterior to the bronchus versus the left pulmonary artery, which lies superior to the bronchus. So the relationship of pulmonary artery, whether it is in the right lung or it is the left lung, is different. There is like a mnemonic, which is RALS, right anterior, left superior. So the right pulmonary artery anterior to the bronchus, while the left pulmonary artery superior to the bronchus. So this is RALS, right anterior, left superior. And the carina, this is the carina, which is like the bifurcation point of the trachea, also has an important relation. So this is the descending aorta lying like posterior lateral to it. So this is the descending aorta versus the ascending aorta lying anterior to the carina. So the anterior is the carina, which is the bifurcation point of the trachea, has a relation with the descending and the ascending aorta. The descending aorta posterolateral to it versus the ascending aorta lying anterior to the carina. This is the pulmonary artery, and this is the superior vena cava. So again, this is the left lung versus the right lung. The left lung has the left upper lobe and the left lower lobe, and due to the presence of the heart on the left side versus the right lung, right upper lobe, right middle lobe, and right lower lobe. And lastly is aspiration. We've talked about that the aspiration pneumonia or foreign body aspiration, commonly affects the right lung because the right bronchus is more in line with the trachea being shorter and being wider. And we've talked about the different location according whether the patient is supine or lying on the side or standing while aspirating. So guys, this is a high yield topic, which is lung volumes and the flow volume loops. I'm gonna break it down. So first you have to concentrate on the main volume, which is the tidal volume. We have primary volumes, which are inspiratory reserve, tidal volume, and expiratory reserve and residual volume. And there are other volume, which are the sum of adding two or more primary volumes together. So first is the tidal volume. The tidal volume is like the quiet inspiration and expiration without putting so much effort. More effort to this is the tidal volume, which are this narrow strip here. This is the tidal volume. And of course, after you inspire quietly, you may add more effort and inspire more air. So this more air is called inspiratory reserve volume. So this is a reserve that you can inspire with adding extra effort. So this is the inspiratory reserve volume. So after a quiet expiration also, there is some volume that you can still expire, which is expiratory reserve volume. So we have expiratory reserve volume and inspiratory reserve volume and the tidal volume. After you fully expirate, and of course you want to get all of the air in your lung out, there is some air that is gonna stay in your lung, which is the residual volume. So this is the volume that is residual and that's gonna reside in your lung after you fully expirate. So this is are the primary lung volumes, and these are lung volume are the sum of two or more of the primary lung volume. So the total lung capacity, of course, is the sum of all lung volumes, inspiratory reserve, tidal volume, expiratory reserve, and residual volume. And there is inspiratory capacity. What is inspiratory capacity? It starts, you're gonna calculate it after normal quiet expiration, normally quietly expire. So this you are at this point, and to take any air that you can inspire, including the tidal volume and also the inspiratory reserve volume. So this is the inspiratory capacity. At the same, by the same logic, this is the functional residual capacity, which includes the expiratory reserve volume and the residual volume. So this is the functional residual capacity, and the vital capacity from its name vital. So it will include all of the volume except the residual volume because the residual volume is not vital. So the vital capacity is gonna include the inspiratory reserve and tidal volume and expiratory reserve. It only not gonna include the residual volume. So if we understand the volumes, lung volumes from the past slide, there's some change in it in obstructive disease versus the restrictive disease. So the obstructive lung disease, for example, such as COPD versus the restrictive disease, for example, such as interstitial lung fibrosis. For each one of them, there is some distortion of the normal smooth lung volumes. So the obstructive lung disease capacity ratio, so the FEV1 forced expiratory volume in 1 second. So forced expiratory volume in 1 second over forced vital capacity normally is 70% or more. So in 1 second, you have to exhale more than 70%. If you can't do that, and forced expiratory volume, FEV1 over forced vital capacity is less than 70%. This means there is some obstruction. The air is not like going out easy, and there is a retention of air and the so you have to memorize this number very well. FEV1 over FEVC ratio decrease below 70% means obstructive lung disease. Total lung capacity increases because like the primary pathophysiology here is air trapping, so the residual volume is gonna increase and the functional residual capacity, remember functional residual capacity equals residual volume plus expiratory reserve volume. So this expiratory reserve volume and this is the residual volume. So this is the functional residual capacity is gonna increase in obstructive disease. So total lung capacity increases, FEV1 over FEVC ratio decreases below 70% versus restrictive lung disease where the FEV1 over FEVC ratio stays normal or it may like reciprocally increase like 80% for example or 85% in some vignettes. So it is a restrictive lung disease. Total lung capacity decreases. Of course, there is like fibrosis here. This is like muscle weakness, myasthenia gravis, or whatever, either external or internal to the lung. So this is restriction of lung expansion. So the total lung capacity is gonna decrease due to the reduction in lung expansion. For example, fibrosis and the pneumonitis. So this is the lung volumes and the distortion of it in obstructive versus restrictive lung disease. Another high yield topic we are going to break up is pulmonary circulation. So pulmonary circulation is high compliance, low resistance circulation, and under hypoxic states, there is like hypoxic vasoconstriction to redistribute blood to like the well ventilated alveoli to compensate for this hypoxia. There are two terms you have to know: perfusion limited, the pulmonary circulation being perfusion limited, and the diffusion limited. What do we mean by being perfusion limited? So this is for oxygen under normal health, CO2 and nitric oxide. So you have to memorize this. Oxygen under normal health, CO2 and nitric oxide, there is equilibration of gas early along the length of the capillary. So along the early length of respiratory, like bronchioles and alveoli, there is equilibration of the gas. The gas is gonna pass fast, and there is early equilibration. For example, at this graph, when you look at this point, there is early equilibration of oxygen under normal condition. Unlike, for example, oxygen under diseased conditions such as emphysema and fibrosis, there is late equilibration. So this is like this dashed line. There is late equilibration at this point. Unlike oxygen under healthy condition where there is early equilibration. So whenever there is early equilibration of gas and the fast exchange of gas, the concentration to reach more concentration of gas, this won't happen. All this will happen only if we increase the perfusion. So this what we mean by saying perfusion limited. So you gonna increase the gas concentration, which by these gases I mean oxygen under normal conditions, CO2 and nitric oxide, only if you increase the blood flow. Unlike oxygen under emphysema and fibrosis. So for this under fibrosis, for example, the equilibration is reached late. So this is diffusion limitation. So this is what we mean by diffusion limitation. So for disease states that leads to diffusion limitation, such as pulmonary fibrosis, we notice more likely to be an early hypoxia than hypercapnia. The people who have pulmonary fibrosis more likely to have early hypoxia than to have early hypercapnia. When the gas reaches equilibration late along the respiratory bronchioles and alveoli, is this what we mean by diffusion limitation? This happens with oxygen under disease condition such as emphysema and fibrosis and CO. CO has like some diffusion limitation, so it reaches equilibrium late along the respiratory tract. So the gas does not reach equilibrium by the time the blood reaches the end of the capillary, and the oxygen diffuses slowly under this diseased condition, while the CO2 still diffuses very rapidly. So again, this is why, and in pulmonary fibrosis, for example, we notice early hypoxia than hypercapnia. Another very high yield topic is oxyhemoglobin dissociation curve. So the oxyhemoglobin dissociation curve here has a sigmoidal shape, and this is due to positive cooperativity of the oxygen. When the oxygen binds to hemoglobin, hemoglobin can bind this, four molecules. So with the addition of each molecule, there is an incremental increase of the affinity of hemoglobin to oxygen. So this causes a sigmoidal shape and the positive cooperativity. So there is something called right shift and something called left shift. And this is the idea behind that. There is some places in your body where the hemoglobin needs to keep the oxygen, and the other places that hemoglobin needs to let go of oxygen. So this is related to mainly to metabolism. So an easy way to memorize the causes that causes left shift. So the left shift means increase affinity, increasing affinity and decrease unloading. So the hemoglobin will not let go of oxygen easily. And so this happens in the condition when there is a decrease in the metabolism. For example, decrease CO2, decrease hydrogen, aka so either like here respiratory alkalosis and metabolic alkalosis. So this metabolic alkalosis, respiratory alkalosis, aka increase in the pH. So first cause decrease in the temperature. Decreasing in the temperature is accompanying decrease in metabolism. We don't need so much oxygen here, so there's left shift. The oxyhemoglobin dissociation curve is shifted to the left. The hemoglobin will not let go of oxygen easily. We don't need so much oxygen. There is a decrease in metabolism and to decrease 2,3 bisphosphoglycerate and some forms of hemoglobin such as fetal hemoglobin, which has a high affinity for oxygen, and some poisoning such as CO poisoning, methemoglobinemia, and some hemoglobin mutation. This condition is gonna cause toxicity by keeping the oxygen stuck to hemoglobin and decrease oxygen available for tissues. So remember, left shift, the hemoglobin is gonna keep oxygen and will not let it go easily. So this is what we mean by left shift, increase hemoglobin affinity and decrease unloading. This is unlike right shift. Right shift is the opposite of left shift. So this occurs when there is an increase in the metabolism. We need more oxygen. For example, increased CO2 is accompanying increase in metabolism. This is called the Bohr effect. This occurs as the tissue side. So as the tissue side, the hemoglobin needs to let go of oxygen to provide oxygen for the tissues to do metabolism. And the CO2, increase in the CO2 cause a right shift or increase of letting go of oxygen. So also increase in the hydrogen increase, aka acidosis. This also increase cause right shift, increase temperature, for example. So this is an indicator of increasing metabolism. So to memorize this causes anything that indicate an increase in metabolism, increase CO2, increase hydrogen, increase temperature, increase 2,3 bisphosphoglycerate accompanying hypoxia and altitude. So all of this condition, we need the oxyhemoglobin dissociation curves to be shifted to the right to provide more oxygen to do metabolism and so to provide the tissues with the oxygen needed for metabolism. So this is the cause gonna cause left shift versus the cause is gonna cause right shift. Next is the carbon dioxide transport in the blood. So the carbon dioxide, CO2, is produced as the tissue side during metabolism. For example, it combines with water, with enzyme carbonic anhydrase and produce H2CO3 that is gonna degrade into hydrogen and the bicarb. So the bicarb is gonna counter like transported with chloride. The chloride is gonna go in from the plasma and the bicarb is gonna go out into the plasma. So this is the major way, like 70% or approximately 70% of the CO2 is like transported this way through the plasma mainly. So this is the main way of CO2 transport is through like being converted into bicarbs and being transported through the plasma. Another way is CO2 binding with hemoglobin. So carbaminohemoglobin is gonna bind at the N terminal of the globulin. Very, very high to know that the CO2 won't bind with like the heme, but it is gonna bind with the globin. So it's gonna bind with the globin, not heme at the N terminus. So this is the carbaminohemoglobin, like 20% of the CO2 transport, and the rest is the 10% through the transport as dissolved CO2 in the plasma. So um, after the uh, after reaching the lung and with the oxygenation of the hemoglobin, there is an increase in the hydrogen release due to oxygenation. And the opposite happens. The hydrogen is available for us. There is an increase in hydrogen, and this is gonna go at reverse, and the bicarb is gonna combine with hydrogen, and finally we're gonna have CO2 to be like released at the lung and exhaled. So the opposite occurs at lung. Is called the Haldane effect. So this Haldane effect is the way we're gonna get rid of CO2 at the lung. So this is for the transport of carbon dioxide through the blood. Then we have the ventilation over perfusion mismatch and different lung zones. So what we mean by ventilation and perfusion mismatch. So ideally, the ventilation over perfusion equals 1. So there is an equal ventilation and perfusion so for optimal gas exchange. So uh, but this isn't like the case always. There is a difference between apex of the lung, for example, and the base of the lung. For the apex of the lung, the ventilation of the perfusion equals 3. This means that ventilation is more than the perfusion. It is more than 1. So the ventilation is more than the perfusion, and the number at the base of the lung is 0.6. So this is less than 1. This means that Q here is more than the V. The perfusion is more than the ventilation. So for the apex of the lung, the ventilation is more than the perfusion. So this is a wasted ventilation. While at the base of the lung, it's 0.6. So this is a wasted perfusion. So both ventilation and perfusion, as a rule of thumb, are higher at the base of the lung than the apex. So these proportion doesn't mean that the apex has like more ventilation and perfusion, but it's like the relation between the ventilation and the perfusion. But the ventilation and the perfusion both are higher at the base of the lung, but the proportion is different. The proportion only, not the whole quantity. And exercise, for example, increase the cardiac output and increase the capillary dilatation. Remember, at the apex of the lungs, there is wasted ventilation. So we have more air, but less blood to make an exchange of gas with this. So at the exercise, at the apex of the lung, with the increase in the cardiac output, there is an apical capillary dilatation. So we will have more blood to like match this increase in the ventilation. So the proportion reaches 1. So the Q increases, and to reach and like a value around V. So it's gonna be around 1. So with exercise, with the increase in the cardiac output, there is an apical capillary dilatation, and the ventilation over the perfusion ratio approaches 1. And this is why high oxygen like consuming organisms such as TB, for example, favors the apex of the lung where there's so much air compared to like the blood. There are some extremes of conditions such as ventilation over perfusion equaling 0. So anything above equals 0, the whole ventilation over perfusion is gonna be 0. So this is equals airway obstruction. So the ventilation is gonna be 0 when there is an airway obstruction, for example, foreign body aspiration. So there is an airway obstruction. So if we give even 100% of oxygen, we want to improve the BaO2. The BaO2, the pressure of the arterial oxygen, BaO2, the dissolved oxygen in the blood. The pressure of arterial oxygen won't be increased even if we give 100% of oxygen. This is because the airway itself is like blocked. So it is no use increasing the oxygen concentration V over Q at this condition equals 0. Unlike V over Q equals infinity. V over Q equals infinity because the Q is 0. So the Q is 0 means like there is no perfusion. For example, pulmonary embolism. The pulmonary embolism is gonna block the circulation. But here, the pulmonary embolism may be not complete. There's maybe some partial occlusion, so some partial amount of blood that is gonna pass. And if we give more oxygen as the airway is clear here, and the oxygen is gonna go in and can improve the BaO2. But this is provided the pulmonary embolism is not complete. If it is complete, also there will be no use of giving like more oxygen, but provided the blockage is not complete, if we give 100% of oxygen, we gonna like improve BaO2 or pressure of arterial oxygen. So this is obstructive lung disease overview. So obstructive lung diseases are subdivided into COPD, chronic obstructive lung disease, and asthma and bronchiectasis. Under the COPD, chronic obstructive lung disease, there are four subdivision into chronic bronchitis and emphysema. So the main difference between chronic bronchitis and emphysema is the diagnosis, the type of the diagnosis. So the chronic bronchitis is mainly a clinical diagnosis versus emphysema, which is mainly a radiographic diagnosis. So the clinical diagnosis of bronchitis occurs when we've got productive cough for more than 3 months, more than or equal 3 months for 2 consecutive years. So you have to have 3 or more months of chronic productive cough for more than 2 years or equal 2 years to get the diagnosis of chronic bronchitis. So the hallmark about chronic bronchitis is the increase in the mucus production, and this is translated at the histological level as the increase in the mucus thickness, mucus layer thickness to be more than 50% from the epithelium to like the cartilage to from the thickness of the epithelium to the cartilage. The mucus gland is gonna occupy more than 50%, and there will be an increase in the mucus production. This is called Riot index. So the hallmark of chronic bronchitis is the increase in the mucus production, and the patients are gonna develop hypoxemia, cyanosis, and consequently polycythemia. The hypoxemia is gonna be due to like blockage of the airways by the inspissated mucus, and there will be shunting in the lung, and consequently is gonna be hypoxia and cyanosis. We've got emphysema. Emphysema, on the other hand, is a radiographic diagnosis. So by being a radiographic diagnosis, we're gonna capture it on the chest X-ray as we've got here. We've got like increased lung translucency, and there is a flattening of diaphragms. We've got flattening of diaphragm here, and if you've got like lateral chest X-ray, you will find increased anterior posterior diameter. This is gonna be evident on lateral chest X-ray, and these people will have a barrel-shaped chest on the later stages. And the emphysema is subdivided into centri-acinar emphysema and pan-acinar emphysema. Each one of them has a characteristic pathophysiology. So the centri-acinar type is linked to smoking and is gonna affect more the upper lobe. So centri-acinar type, upper lobe, more linked to smoking, versus the pan-acinar type. The pan-acinar type is linked to some condition called alpha-1 antitrypsin deficiency. So alpha-1 antitrypsin deficiency is anti-protease. So if we got deficiency in alpha-1 antitrypsin, the protease activity is gonna be unchecked, and there will be a destruction of like the airway and the emphysema. So this destruction is gonna cause increase in compliance. So the lung will be more compliant, it will trap more air, and there will be decrease in recoil due to destruction of the texture of the lung, and there will gonna be reduced DLCO, diffusion capacity of CO, carbon monoxide. We have talked about that before, that CO has like characteristic diffusion limitation, and it's gonna be affected in emphysema, for example, or like fibrosis, versus CO2, which is more easily like diffuse, even if lung is destructed. This is why We get like hypoxia before hypercapnia, as we have talked about it in interstitial lung fibrosis, for example. So emphysema again is a radiographic diagnosis versus chronic bronchitis, which is mainly clinical diagnosis with mucus production for more than 3 months for 2 consecutive years. And another obstructive lung disease is asthma. So asthma is peculiar because unlike bronchiectasis, for example, where the patient is gonna have symptoms all the time, the asthma is like episodic. It happens in episodes. So if you auscultate the chest of a patient with asthma, for example, during an episode, you're gonna find wheezes, and between the episodes, the chest is gonna be completely normal for some times. So this is a reversible bronchoconstriction, and the mechanism behind it is a type 1 hypersensitivity reaction. And the diagnosis is going to be clinical, as we have said, by auscultation and finding wheezing during episodes and spirometry. So if we do spirometry during these episodes, there will be a, a obstruction, and it's going to be characteristic for asthma. And it's gonna be confirmed by giving a bronchodilator test and positive response to bronchodilator test. This is gonna be confirming the diagnosis even. So this is if we do spirometry during the attacks. So, but if we do spirometry in between the attacks, and we have to do something called the mesacholine challenge test, so we're gonna stress the lungs to go into bronchoconstriction by giving a mesacholine and watch out for like the characteristic spirometric pattern for asthma, and this is we need this if the patient is in between episodes. So at the histological level, we've got like characteristics, things that you have to just know, such as Charcot-Lyden crystals. So this is eosinophilic. Charcot-Lyden crystals is hexagonal, eosinophilic, due to like the breakdown of eosinophils. And we've got Crashman spirals. Crashman spirals, these are like shed epithelial cells. It's gonna like be horlid like mucus plugs. So horlid mucus plugs formed from shed epithelium. So this is the origin of it is epithelial cells transformed into mucus plugs, and this is like eosinophilic hexagonals shaped due to like breakdown of eosinophils. We've got our third disease, obstructive lung disease, which is bronchiectasis. So bronchiectasis is characterized by chronic cough and daily purulent sputum. So this is more like bronchitis, but the bronchitis is the sputum is gonna be for like some period of the year to diagnose it, not have to be daily like bronchiectasis. But bronchiectasis is characterized by its sputum being purulent, so very characteristic. And recurrent pulmonary infection, also very characteristic for bronchiectasis. So the hallmark about bronchiectasis is pulmonary infection and having daily purulent sputum. Daily, it's gonna be daily, it's gonna be purulent, and there gonna be recurrent pulmonary infection. And the diagnosis is confirmed by imaging showing like airway dilatation. So it is more like emphysema and is having like characteristic CT and chest X-ray picture where we have like airway dilatation and bronchial wall thickening. And of course, we have obstructive pulmonary function test. So the obstructive pulmonary functions is the FEV1, forced expiratory volume in 1 second over forced vital capacity. FVC is less than 70%. So when we've got this, we are under the category of obstructive lung disease, which includes COPD, asthma, and bronchiectasis. And there are common etiologies for bronchiectasis, such as airway obstruction. The patient may have a foreign body or tumor, for example. So this is gonna start the whole process up to bronchiectasis. So the beginning of this condition may be due to airway obstruction by foreign body or tumor, or some poor ciliary motility, such as smoking, which is gonna hinder ciliary motility, smoking. So smoking may be a predisposing factor for bronchiectasis and the Cartagena syndrome, which is like a defect in the inner arms. So as a consequence of Cartagena syndrome, chronic sinusitis, and bronchiectasis, and male infertility. So this is Cartagena syndrome again, sinusitis, bronchiectasis, and the male infertility, cystic fibrosis, and the defect in chloride channels, and having inspissated mucus plug is gonna be like is gonna cause obstructions such as like foreign bodies, like the mechanism of foreign bodies. So cystic fibrosis causing inspissated mucus plugs is also a predisposing factor. Allergic bronchopulmonary aspergillosis, so aspergillus fungus, it may also be a predisposing factor. Allergic bronchopulmonary aspergillosis and chronic infections by Mycobacterium avium, for example. So bronchiectasis is like having daily symptoms, having a daily purulent sputum, and having recurrent pulmonary infections. If you do like CT, you're gonna find airway dilatation and bronchial wall thickening. Also memorize causes again, airway obstruction, foreign bodies and tumors, pulmonary motility, either due to smoking or Cartagena syndrome, cystic fibrosis, and having inspissated mucus plugs, allergic bronchopulmonary aspergillosis, and chronic infections such as Mycobacterium avium. On the other hand, we've got the group of restrictive lung disease. So the most common disease under this category is idiopathic pulmonary fibrosis. So this includes like various cycles of inflammation and fibrosis, and going on and on till we've got the picture of idiopathic pulmonary fibrosis may include things that's gonna like a On the other hand, we've got another group, which is the restrictive lung disease group. Under this category lies, for example, idiopathic pulmonary fibrosis, which is the most common type. So its etiology is unknown from its name. It's idiopathic pulmonary fibrosis. It's idiopathic, and there are like multiple cycles of injury, inflammation, and fibrosis on and on. Maybe due to genetic conditions, there may be like due to bullions and smoking, for example. So these are just hypotheses. And there will be progressive fibrosis. So the progressive fibrosis, the picture of this is gonna be like reticular obesities peripherally in the lungs. We'll find reticular obesities and like traction, bronchiectasis as a periphery till we progress, and we've got like honeycombing. So honeycombing is in later stages of idiopathic pulmonary fibrosis. And we also pneumoconiosis. So the pneumoconiosis is under the restrictive lung disease causes, such as there are like subcategories of pneumoconiosis, asbestosis, and coal workers lung disease. This is the pneumoconiosis. These are the pneumoconiosis, and also sarcoidosis. So sarcoidosis can cause like interstitial lung disease, and the sarcoidosis is characterized by non-caseating granulomas all over the body that is not that's gonna cause like for example, bilateral higher lymphadenopathy, very, very characteristic for sarcoidosis. Also, parotid enlargement, like parotid enlargement, increased ACE inhibitors and the calcium and vitamin D, all of this like markers for sarcoidosis. So these are things that is associated with sarcoidosis, and the hallmark of it is non-caseating granuloma. And the hypersensitivity pneumonitis, this is like a type 3/4 hypersensitivity reaction to inhaled like antigens such as birds and molds. So it's also can cause restrictive lung disease. Also drug-induced due to bleomycin, busulfan, amiodarone, and methotrexate. Memorizes these drugs, bleomycin, busulfan, amiodarone, and methotrexate. Radiation-induced lung injury also can cause restrictive lung disease early as pneumonitis and later as fibrosis. Also granulomatosis with polyangiitis. It's a C-ANCA positive, and it's gonna affect sinus and lung and kidney by causing vasculitis in different organs. Also is a cause of restrictive lung disease and pulmonary Langerhans's histiocytosis. So there's the disease of young smokers. It will have like cystis and nodules in the lung characteristic by having cystis, both cystis and nodules in the lung happening in young smokers and having such biopic granules. So these are like characteristics for pulmonary Langerhans and histiocytosis. So The restrictive lung diseases, idiopathic pulmonary fibrosis, as we have just said, this is a progressive interstitial lung disease having honeycomb lung appearance, and like at the later stages of the disease. We've got X-ray here for fibrosis, and the CT also showing lung fibrosis. You have to like to memorize these pictures in case if you ask it about it, if you are asked about it in your exam. And the pneumoconiosis will have like co-worker lung disease. So the characteristic for it is being plaque. Plaque lung is the co-worker's lung disease. Silica exposure. So silica exposure have a characteristic eggshell hilar node calcification. So very characteristic eggshell calcification in the hilar lymph nodes is associated with silica. Asbestosis, on the other hand, it have a characteristic bodies called ferruginous bodies. This happens mainly in the lower lobes. Another highly tested point for asbestosis is its association with bronchogenic carcinoma. So the most common cancer associated with asbestos is bronchogenic carcinoma, not mesothelioma. Sarcoidosis and hypersensitivity pneumonitis as a causes of restrictive lung disease. So sarcoidosis, mainly non-caseating granuloma, characterized by increased ACE and hypercalcemia, while hypersensitivity pneumonitis type 3 slash type 4 hypersensitivity and due to, for example, exposure to the forms and molds, for example.
Lung cancer is pretty deadly. It is the leading cause of cancer deaths worldwide. So there are common symptoms for lung cancer such as cough, hemoptysis, and wheezing, muscle like weight loss, cachexia, and they are not pretty specific for lung cancer. For example, hemoptysis, you may find it with pulmonary edema, bronchiectasis, and the cough. It may happen with like pneumonia and bronchitis. So the next step is to do some imaging, chest X-ray and the CT scan. So the lung cancer is subdivided into two big groups, the small cell lung carcinoma and the non-small cell lung cancer. So the small cell lung carcinoma has like a pretty specific location. It tends to occur central in your chest. So you have to memorize this is a very high yield point. So the small cell lung cancer plus the squamous cell carcinoma occur centrally. They have central location in your chest X-ray versus adenocarcinoma, which occurs peripherally, for example. So the behavior of small cell lung cancer, it has like an aggressive, very aggressive tumor and has undifferentiated histology, and it has like a very important like thing which is paraneoplastic syndromes. So the paraneoplastic syndrome of small cell lung carcinoma, they are highly tested, specifically the endocrine ones. So they are neurological paraneoplastic syndromes and endocrine paraneoplastic syndromes. The neurological paraneoplastic syndromes include Lambert-Eaton myasthenic syndrome. So it's like muscle weakness and due to substances like associated with small cell lung cancer, and it causes like anti-calcium effect. So by this way, it can uh, calcium channel like anti-calcium channel. By this way, it's gonna cause like muscle weakness and also paraneoplastic myelitis, paraneoplastic encephalitis, and subacute cerebellar degeneration. So whenever you find small cell lung cancer and one of these, this is like paraneoplastic syndromes of small cell lung cancer. And what is most commonly tested is the endocrine paraneoplastic syndrome. For example, if you've got like a patient who has a chest X-ray with like suggestive lung cancer plus a sodium of 120, 125, this is SIADH. So this is an endocrine paraneoplastic syndrome, syndrome of inappropriate antidiuretic hormone. So whenever there is increase in the antidiuretic hormone, there is increase in water retention. So when you with this water retention, it's gonna be like hyponatremia. So this is when you find in a vignette a patient who has like again lung cancer plus low sodium. So this is SIADH, and also Cushing's syndrome may happen as a paraneoplastic syndrome associated with small cell lung cancer. For example, there is a suggested this is through like increase in the ACTH. So the ACTH is the mediator here. It increases and it's gonna like cause Cushing syndrome with which all of its manifestation: hyperglycemia, hypertension, the stria that is a characteristic of Cushing syndrome. So you have to watch for any of these accompanying lung cancer. So this is mostly like a paraneoplastic syndrome of this lung cancer. So the location again is central location and differentiated very aggressive tumor, and the treatment is primarily chemotherapy. For you have to give like chemotherapy plus radiation. So you may give chemotherapy with or without radiation. So primarily you have to give chemotherapy. And regarding the histology, it arises from specific cells called neuroendocrine cells called Kolchitsky cells. So this Kolchitsky cells has like basophilic appearance as appears here in this histology picture. So it's like basophilic neuroendocrine cells, Kolchitsky cells, and it has like a chromogranin A positive, neuron specific enolase positive, synaptophysin positive. So these markers you have to memorize them. So again, chromogranin positive, neuron specific enolase positive, and synaptophysin positive. So this is all for small lung cancer, the location, like its behavior, the treatment, and the paraneoplastic syndromes of small cell lung cancer. Then we gonna talk about like non-small cell lung carcinoma. It is subdivided into adenocarcinoma, squamous cell, and large cell carcinoma. So first is adenocarcinoma. It has a peripheral location, as we have just said, and it is most common like in non-smokers, and the female occurs more commonly in females than in males. So this is a very high yield point, and non-smoker is a tumor not related to smoking. Very high yield point is that to know that adenocarcinoma is not related to smoking. And there are some specific mutation you have to memorize this: KRAS mutation, EGFR mutation, and ALK mutation. So KRAS, EGFR, and ALK mutations are associated with adenocarcinoma, and the clubbing is common. Another name, which is hypertrophic osteoarthropathy. So hypertrophic osteoarthropathy is associated with some conditions such as bronchiectasis, for example, and cyanotic congenital heart disease. And here is pretty associated with subdivision of non-small cell lung carcinoma, which is adenocarcinoma. So this is like and picture of like adenocarcinoma. It has like mucin and stain positive for mucin. This is adenocarcinoma, and squamous cell carcinoma. It has like central location, which is the same as a small cell lung carcinoma, and link it to smoking versus like adenocarcinoma, which is not related to smoking and can cause hypercalcemia. This is another high yield paraneoplastic syndrome. So this is paraneoplastic syndrome associated with squamous cell carcinoma. This is mediated by something called the parathyroid hormone related peptide. So for this patient, when you like do some lab tests, and you will find the parathyroid hormone normal. So this is kind of tricky. So parathyroid hormone itself is normal, but parathyroid hormone related peptide is the thing that is increased in squamous cell carcinoma, and the thing is gonna mediate like hypercalcemia in the patient who has squamous cell carcinoma. And on histology, it's like keratin barrels and like desmosomes and intercellular bridges. So on like chest X-ray, you may find like cavitation. So the cavitations like pretty specific for squamous cell carcinoma. So cavitations on chest X-ray, and the keratin barrels on like as here in like on the histology keratin barrels. So and the next subdivision of non-small cell lung cancer is large cell carcinoma. So again, it has like a peripheral location, and is highly anaplastic. Large cell carcinoma is very aggressive, highly anaplastic, with poor prognosis, and the treatment is surgical treatment, and may produce like gynecomastia by secreting HCG. So it can secrete HCG, and it can cause gynecomastia. So to recap, like the paraneoplastic syndrome, or like things associated with like lung cancer. So large cell carcinoma is associated with like gynecomastia through HCG. Squamous cell carcinoma is associated with like hypercalcemia through parathyroid hormone related peptide. Adenocarcinoma can cause like hypertrophic osteoarthropathy, like clubbing, and of course the paraneoplastic syndromes of small cell lung cancer, the endocrine one, Cushing syndrome, and SIADH, and the neurological one, Lambert-Eaton myasthenic syndrome, paraneoplastic myelitis, and encephalitis, subacute cerebellar degeneration. So you can like put some effort in memorizing them well. So, there's some high yield subtype of like Bancost tumor and superior vena cava like syndrome. So Bancost tumor is like a type of lung cancer which has like a specific location. It has like it occurs like upward in your chest near like the blood vessels and the brachial plexus. So having like this specific location is gonna cause some compressive symptoms. So it can compress the nerves. So when it compresses the stellate ganglion, it can cause Horner syndrome. So ptosis, meiosis, and hydrosis, dropping of your eyelids. The eyelids is gonna constrict, the pupils is gonna constrict, and there's like no hydration or like no sweating on one side of your head. So this is like Horner syndrome. And the cause is due to compression of stellate ganglion by the tumor. So also hoarseness. This is occurs due to like uh, pressure on the recurrent laryngeal nerve. So when this tumor like compresses the recurrent laryngeal nerve is gonna cause like hoarseness and the pain. The pain occurs due to the compression of the brachial plexus. So the when the tumor compresses the brachial plexus can essentially cause any symptoms, for example, shoulder pain, sensory motor deficit. So according to the nerve root or the nerve branch compressed of the brachial plexus, it can cause like all of the sensory and motor deficits in your like arm and atrophy, for example, intrinsic muscles of the hand, anything. And another high yield thing that can cause like Bancost tumor can cause a superior vena cava syndrome. So superior vena cava syndrome can be caused by Bancost tumor. Also, it can be caused like by, for example, central venous catheter, like causing some thrombosis. So either some thrombosis from within the vessels or being like compressed from the outside by Bancost tumor. So the blood is gonna be the pressure is gonna be stagnant. The blood is gonna be stagnant, and the pressure increases backwards. So the superior vena cava is like compressed, and the blood will go back in your head and in your arms. So there's like edema in your head, in your arms, and even like the pharyngeal edema, laryngeal edema. So the pharyngeal edema is gonna like affect your pharynx, and laryngeal edema is gonna cause like hoarseness, and there's like upper limb edema or head edema. This it may even cause like, for example, like rupture of aneurysm in your brain and the headache and all of these neurological symptoms. So this is due to like the back pressure of the blood is not gonna reach easily to your like right atrium from the superior vena cava. So this is superior vena cava syndrome, and it has like pretty specific characteristic when you're like press on your the skin of the patient above like the obstruction is gonna cause blanching after you press on your patient's skin. So this is for superior vena cava syndrome, and there are another like tumors like lung cancers, hamartomas. They are like incidental will circumscribe lung masses on imaging, and bronchial carcinoid tumors. They are like may occur central or peripheral. So for every tumor, it can occur either central or peripheral. So bronchial carcinoids has like a specific thing being occurring like both central and peripheral either. So rarely metastasize and has like good prognosis and can cause like carcinoid syndrome. So remember, carcinoid syndrome, it primarily it either occurs due to bronchial carcinoid tumor, or it may occur due to like intestinal like carcinoid tumor. So the intestinal carcinoid tumors have to like metastasize in the liver to cause like carcinoid syndrome. So as long as it stays in the intestine, it's not gonna like cause the symptoms of carcinoid syndrome, such as like wheezing, flushing, diarrhea. This is because the intestine is drained by the portal vein, and like the serotonin, which is a mediator for for the carcinoid syndromes in general, when it is drained from the intestine, it's gonna go to the liver and be detoxified. So the intestinal like carcinoids have to go and metastasize into the liver to cause like carcinoid syndrome, versus the bronchial carcinoid tumors is gonna cause carcinoid syndrome directly. So it is gonna like pour serotonin directly into your like systemic circulation. So it's gonna cause carcinoid syndrome. So risk factors for lung cancer. we all know of all of them. Tobacco smoking is like the primary risk, including like second-hand smoke. Even second-hand smoke is a risk factor also for lung cancer, and the environmental exposures, radon, asbestos, radiation. So the people like who has like occupational hazards, like uh, for example, the radiology, the technicians. So other factors such as pulmonary fibrosis and family history such as EGFR mutation. So the people having EGFR mutation are increased for lung cancer. So the sites of lung cancer metastasis, it can metastasize into liver, adrenals, bone, and brain. So these are like the four sites that lung cancer tends to metastasize for. So if you have like an accompanying symptom such as jaundice, hepatomegaly, so it's probably metastasized into your liver, adrenals, or pathological fractures. So it is gonna, this means it has metastasized to your bone, brain, of course. So and lung metastasis versus primary tumors. So it is a high yield point to know that the most common cause of lung cancer is metastasis. So also we have talked about small cell cancers and non-small cell lung cancer with all of their subtypes. Like metastasis remains the most common cause of lung cancer. So lung metastasis are the most common cause of lung cancer, and you like know that these are metastases by they have usually like multiple lesions in like maybe in both of lungs in the different like loops. So by this way you're gonna know it is metastasis, not a primary tumor. So the primary source for these metastasis is like breast, colon, and the prostate. So we're gonna talk about pulmonary hypertension. So the definition of pulmonary hypertension is the increase or elevation of the pulmonary artery pressure more than a specific cutoff point, which is 20 millimeter Hg at rest. So whenever there is an increase of the pulmonary artery pressure more than 20, this is pulmonary hypertension, and this causes some changes such as arteriosclerosis, and some the media of the pulmonary artery is gonna like hypertrophy to pump more blood. So there is gonna be medial hypertrophy and the intimal fibrosis. The intima is gonna be injured from the increase of blood pressure. So this like at the end is gonna increase the pressure at your right side of your heart. So the right increase in the right ventricular pressure, and then right ventricular hypertrophy, and eventually the right ventricle will fail, and there will be right ventricular failure. So this is for the consequences of pulmonary hypertension. So there is a lot of etiologies for pulmonary hypertension, and they are classified under 5 groups. So the group one, pulmonary hypertension. So this refers to the heritable causes of pulmonary hypertension, often like idiopathic. And here in group one, their females are affected more than in males. And like heritable cause of pulmonary hypertension, there is some PMPR2 gene mutation. So this inactivating mutation of PMPR2 gene. So normally the PMPR2 gene is gonna inhibit like the smooth muscle hypertrophy. So if there is inactivating mutation in this gene, the smooth muscle is gonna hypertrophy, and the lumen of the pulmonary artery is gonna decrease, and the pressure is gonna build up in the pulmonary artery. So this is the heritable cause of pulmonary hypertension. Also, there is imbalance of the endothelium, which is constrictor mediator versus like nitric oxide and the prostaglandin, which are vasodilators. So this group of pulmonary hypertension has poor prognosis. So this is for heritable pulmonary hypertension. There are also another like diseases that are classified under group one, such as HIV. HIV can cause pulmonary hypertension, and the connective tissue diseases, such as like scleroderma. So also the amphetamines and the cocaine, they are like drugs which can cause this. Even schistosoma may cause pulmonary hypertension and is classified under this group one. So this is for group one pulmonary arterial hypertension. Group two pulmonary arterial hypertension occurs due to left heart disease. So whatever the disease in the left heart, systolic, diastolic dysfunction, valvular heart disease, eventually the left side is gonna fail to pump blood into the systemic circulation, and there will be build up of pressure that is transmitted into the pulmonary vein first and then through the lung into the pulmonary artery. So this like cascade of events is termed group 2 pulmonary hypertension, left heart disease causing pulmonary hypertension, and right heart disease. So this is group 2. Group 3 lung disease slash hypoxia. So this includes COPD, interstitial lung disease, even the hypoxic state such as sleep apnea or living in high altitude. So normally there is a ventilation perfusion mismatch, VQ mismatch, and when there is some diseases such as these, the lungs is gonna respond by causing some vasoconstriction to shift blood from the diseased or ill ventilated alveoli into the good ventilated alveoli. So this vasoconstriction is gonna which is needed like to increase the saturation, has some drawbacks. It's gonna be transmitted into back into the pulmonary artery and is gonna increase the pulmonary pressure. So this is a group of lung disease slash hypoxia causing pulmonary artery hypertension. So the group 4, which is chronic thromboembolism. So we are here not referring to like thrombosis of the pulmonary artery, like DVT, and sending like big thrombus causing hemodynamic instability or chest pain, but we are talking about recurrent microthrombi. So the microthrombi is gonna reach like the terminal pulmonary artery like branches, and over time is gonna reduce the pulmonary vascular bed area, and by this way there will be also a build-up of pulmonary artery pressure, so gonna also cause pulmonary hypertension. The group 4 5 is multifactorial, any other rare causes, and like systemic disease, metabolic disorders, hematological disorders, even vascular compression by tumors such as compression of the pulmonary artery by tumor. So all of this is classified under multifactorial category. So this is for pulmonary hypertension. Then we are talking about some physical finding in lung disease. So when we are talking about like pleural effusion, atelectasis, pneumothorax simple, and detention pneumothorax, and consolidation. So first we're gonna compare between them regarding breath sound is gonna decrease in all of them. Either there is fluid or like air in your lung, the air will not go in and out smoothly as normal. So the breath sound is gonna be decreased in all of them. The consolidation also is gonna be decreased, but there's gonna be like some specific bronchial breath sound like egophony, some respiratory crackles. So by consolidation, we are referring to disease such as pulmonary edema and pneumonia. So as a level of the percussion, if there is like fluid or there is atelectasis, it's gonna be dull, and the presence of air will be causing hyperresonance. So simple pneumothorax, tension pneumothorax, there will be hyperresonance at percussion. The others is gonna stay dull. The fremitus, not very high yield, but this refers to the when the vocal cords produce sound, it's gonna be transmitted down into your like through your lungs, and when you put your like hands over the chest, it's gonna sense that. So it's gonna be decreased in pleural effusion if it is large, and atelectasis, and it's gonna stay normal in consolidation, but in pneumothorax you will not hear like, since the air is gonna impede the transmission of this, and there will be no fremitus. And the tracheal deviation, so the tracheal deviation depends like occurs in pleural effusion and the pneumothorax, but it depends on the quantity. So if there is a pleural effusion is large enough, it's gonna like shift the lung, like it's gonna shift the trachea to the other side. And by the same concept, if the pneumothorax has a high tension, it's tension pneumothorax is gonna like shift the trachea to the other side. So this depends on the like the quantity and the tension for the pneumothorax. And the digital clubbing is important like topic. So this refers to increasing the nail angle more than 100, smooth 180, not very important. And there's some pathophysiology also that is low yield, which is there's refers to a theory of the presence of the intra like pulmonary shunts and the platelets being lodged into the nail bed, and the secretion of the platelet derived growth factor and the vascular endothelial growth factor. So
After that, it's gonna cause clubbing. So what is important here is the causes. So there are respiratory causes, cyanotic heart disease, infections, and the inflammatory bowel disease, and you have to memorize them well. So that for the respiratory diseases, we are not talking about asthma or COPD. This is the takeaway from this like slide. So the respiratory disease, the usual respiratory disease is going to cause digital clubbing, bronchiectasis, and like interstitial lung disease, lung cancers. So this is the normal like respiratory diseases, and the cyanotic heart disease and the infections, not pneumonia, not bronchitis, but the infections that are gonna cause digital clubbing are TB, for example, and lung abscess. So lung abscess, TB, bronchiectasis, like interstitial lung disease. So these are the normal causes that is associated with digital clubbing, and watch out that asthma and COPD are not like usually normally associated with digital clubbing. You may be tricked by this by in the vignette of some cases. So the atelectasis refers like to the shrinkage and the decrease of volume in your lung. So it has like a lot of causes. So for the obstructive causes, this refers to airway blockage from within, from the inside, from within like the bronchus, for example, by some mucus plug, foreign body. So endobronchial tumor, all of this is gonna like um block it from the inside, and the old air is resolved at like distal to that, and this is the obstructive ones versus the compressive one, which refers to external compression from lungs outside by pleural effusion, for example, and or a space occupying lesion. So this is the compressive atelectasis. Contraction atelectasis refers to like the scarring due to like interstitial lung disease, for example, due to sarcoidosis, associated with sarcoidosis. So there is some distortion of the alveoli and decrease in lung volumes. All of lung volumes are decreased in the restrictive lung diseases, and adhesive one refers to surfactant deficiency. So surfactant is a normal like substance that is gonna prevent alveoli from collapsing on their own. There is a high surface tension, and the alveoli normally tend to collapse on their own. So the surfactants normally prevents that. So this is the adhesive. When there is lack of surfactant, there is adhesive one, such as neonatal respiratory distress syndrome. So pleural effusion refers to fluid accumulation that is gonna restrict like lung expansion. There is mild, moderate, and severe. So this here is white lung. This is like severe pleural effusion, and the mild one is like only obliteration of the costophrenic angle. So this is nice. Costophrenic angle is gonna be obliterated. This is mild pleural effusion. So you have to like differentiate between exudates and the transudates. Both of them may cause pleural effusion, and there is some criteria called Light's criteria that is gonna differentiate between them. So whenever there is the protein in the fluid is more than half of the protein in your like blood, so this is referred to exudate. If the like protein like fusion protein over like serum protein is more than the half, or the LDH is more than 0.6 over the serum LDH, or more than two-thirds of the normal. So this refers to the exudate, and this means like there is a high protein in this fluid. So the exudate may be due to infection or malignancy, and there is something wrong here, and it often needs drainage versus the transudate, which occurs due to increased pressure or hydrostatic pressure in heart failure, for example, or sodium retention, or the decrease in the protein. The decrease in protein may be in nephrotic syndrome or liver cancer. So the decrease in this protein may cause this. And normally we give medical treatment, as if you like drain it, it's gonna like reaccumulate again. So this is transudate versus exudate, and the light criteria. And the pneumothorax. The pneumothorax is like air in the pleural space. So it is primary spontaneous pneumothorax, which is simply rupture of apical blip in some healthy young as a man, for example. This is like the normal demographics that occurs in it. This may be linked to smoking versus the secondary spontaneous. Also, it is spontaneous, but being a secondary, it occurs in diseased lung. For example, in emphysema, the emphysema has like some bully when it ruptures. This is like secondary spontaneous pneumothorax. The barotrauma for ventilation. Also, people with Marfan syndrome may have secondary spontaneous pneumothorax. The traumatic pneumothorax
refers to like being caused by blunt trauma, causing like, for example, rib fracture or penetrating trauma such as gunshot or knife, or iatrogenic injury such as insertion of the central venous catheter. And finally, the tension pneumothorax. This doesn't refer to the mechanism as above types, but whatever the mechanism, the build-up of tension and the air being trapped is gonna cause like the trachea deviation away, as this picture here, and they may cause like obstructive shock. Is gonna like press over the inferior vena cava. The inferior vena cava normally drains blood from the lower half of your body. So when there is interruption of this drainage, there is interruption of the circulation, and there is an obstruction. So this is obstructive shock, and the patient will have like hypotension. And I hope you guys enjoyed our episode for today, and see you in next episode. Thank you.